Today, it will be presented. The outline will be as follows: an introduction, the definition of postoperative nursing, our statistics on the outcome, the experience and the procedure of postoperative care, and a conclusion. Next slide, please. Slide, please. Okay, postoperative nursing care has remained the same over the years, but in recent times, nursing, however, needs to be up to date. When I mean up to date, the nursing has to do with assessment of postoperative care, knowing what to do in case there is a complication and taking action. So it is based on guidelines, on policies, on evidence-based practice. That's what Smile Train wants to put in place for nurses who are doing care. So the nurse, in as much as she does her routine, it is important for the nurse to assess, to decide, and to react when dealing with patients with clefts and cleft lips and palates. Slide, please. So nurses are best placed to detect early changes that occur in a child's condition and may indicate potentially life-threatening complications. Slide. As definition of terms, we have postoperative nursing, which according to New Thesaurus 2018 means happening or done after a surgical operation. So postoperative nursing care is actually the management of a patient after surgery. This encompasses both autonomous and collaborative care of individuals who have, of all ages, of course, who have undergone surgery. Slide. Cleft surgery is almost always an elective surgery, except there is really denutrition and they have to plan the surgery, but almost always an elective surgery. And from my experience as a nurse, several patients whom I have nursed, the recovery has always been uneventful, but this recovery has not always been uneventful because we don't do something. So this happens because the events, because nursing care has been put in place to handle the after surgery period, and nursing care saves lives. I must say that. As the number of cleft surgeries have increased, we will all notice that with all the information, the knowledge we have acquired, sentinel events following cleft surgeries have fallen. The recent years, majority of the sentinel events actually occur 90 minutes after surgery, which means the person is already out of the recovery. And 40% of the problems involve breathing problems. We can verify that with Smile Train and statistic on the statistic page. The British Journal of Plastic Surgery on cleft also states that life-threatening complications in children with cleft are maintaining a patent airway, and with the most serious ones occurring 9 hours post-operatively. Slide. So this brings us to the purpose of our post-operative care. The purpose of the post-operative care is to prevent complications, to promote healing, to return the patient to a state of normal life or a better state of health. It is very crucial to ensure positive outcomes of patients who have undergone surgery. The post-operative nursing care is very crucial to ensure positive outcomes. So the extent of the post-operative care actually depends on the initial state of the patient, and the peri-operative events which occurred. There is no contraindication for post-operative nursing care. The more the nursing care, the better the outcome. However, we need a prerequisite, and that is a trained and skilled nurse capable of carefully monitoring the patient and identifying outcomes and abnormalities. Slide. How is postoperative care done? The postoperative nursing care done. This is done, what I would like to remind here is that the nursing care should never be considered as a routine. The nurse has to always be vigilant and prepare for unanticipated events, because these events can really come. And should they happen, the nurse needs to assess, she needs to decide, and she needs to react. It is very important. Slide. Slide, please. Let me just brief a little bit on the postoperative nursing care. When does it occur? What do we do? There are actually three phases, with the phase one being the immediate post-anesthesia. That is immediately post-anesthesia and recovery, where the patient is actually needs a one-on-one care. Here, the nurse is actually looking at the level of consciousness, the breath sounds, the respiratory efforts, the oxygen saturation, the cardiac rhythm, the blood pressure for adults, and this can last for 1 hour to 1 hour or 90 minutes, and then the patient can be transferred to the nursing unit to the second phase using an Aldrich score. Slide. So in the first two is actually the continuous recovery, where the patient's consciousness returns to normal or to baseline. The patient has a stable pulmonary and cardiac function. But I would like to iterate here that what we normally do, we do a fast tracking, because we are mostly working with the mobile Cleft team. So we often do a fast tracking where the patient leaves the operating room. So we make sure that the patient has recovered in the operating room. All baseline information comes back to normal or to the initial state, and then we take the patient from the operating room to the nursing unit. However, it is important to know that Smile Train is insisting that when collecting a child, before the child goes to the nursing unit, they should be protecting their airway. They should be awake, or at least easily arousable. They should not be in any pain or distress, no bleeding. Vital signs should be stable. The child is not vomiting. And make sure, it's important that the nurse make sure that all post-operative instructions have been documented. And the third phase now, this is now in the nursing unit, where the patient needs ongoing care for an extended period of 23 hours. This is actually the period we call the intensive observation period, where the nurse has to do the vital signs, and after 24 hours, she can continue to do the vital signs according to hospital policy, or every 4 hours until the patient completely recovers and can take care of self or can go home. Slide. So now the nursing care itself is actually a process where we have 5 elements, sorry. It is essential for practice. It is essential to deliver patient-focused care. The nursing process aims at solving the problems of the patient, and it should be holistic. The nurse does the assessment, where she gathers all the information, the documentation. She poses nursing diagnosis. Those are actually the potential or the risk, the actual or the risk problems the patient might come up with. She does a planning, where she sets goals. She programs her intervention. She identifies what will she do in case of anything. Now she goes to the implementation phase, where everything that has been planned must be put in place. And finally, the evaluation to find out if goals prepared have been met. Next slide, please. I would like to emphasize here that in postoperative nursing care, the priorities remain airway, breathing, circulation. And the nurse does the observation for 24 hours intensively without taking any breaks. Slide. During the assessment, the nurse should make sure that all equipment are working. After the surgery, do I have all that is required for my patient? A stethoscope, a pulse oximeter, emergency drugs, a thermometer, everything required to monitor the patient should be handy, and they should be working. They should be functional. So she does this, the post-anesthesia unit, to make sure that all her equipment are there and they are functional. So the first assessment, which we'd like to emphasize on, or which we normally do following cleft surgeries, are actually respiration. Although it is the most undervalued, it is the most important vital sign. Respiration is actually the first vital sign which will change if the patient begins to deteriorate. And how do we do that? We uncover the child before we do the vital signs. We watch the abdominal movements, because children are predominantly abdominal breathers, and we count the movements for 1 minute. Meanwhile, while doing this, it is important to take note of the sounds, the breathing sound. Is there a wheeze, a stridor? Is the child grunting, gobbling, cough? Any abnormal sound, the nurse takes note of that. That notwithstanding, she also takes note of the alterations in the child, which means she has to be observant. She looks, is the child having any nasal flaring, the use of intercostal muscles or subcostal muscles? Is there a tracheal talk? Is there substernal recession? How does the child look like? But I would like to also emphasize that cyanosis is a late sign. It's very late. When cyanosis is seen, it means things are already gone far beyond repair. So some alterations that we will observe when the respiratory rate is increasing, we will have some factors, which may cause an increase in the respiratory rate. We'll have things like respiratory distress. The child may be bleeding, may be in pain, may have a fever or fluid volume excess, while a decrease is actually already indicates that the child is entering into a respiratory failure, or there may be some anesthetic drugs which might have been given intraoperatively. But it is very important to know the value for age, because this is what will guide you to know if there are any alterations. Slides, please. So the next thing we assess is actually postoperatively is the oxygen saturation. The oxygen saturation should not be replaced. We should not replace respiration, please. In as much as it's good to go alongside, it is important for the nurse to make sure that the probe has been placed on a dry, well-perfused finger. There is no nail polish. The child is not agitated or moving. We note the wave, the display of the waves of the pulse oximeter, and the normal value should be equal to or greater than 95%. Should there be any alterations, the nurse should check the body temperature, the work of breathing, the sound of breathing, check the medications given to the child, and how is the child looking like? Is it agitated? Is it silent? The next one will be the heart rate. For children less than 2 years old, we use the stethoscope on the apical pulse. And for children above, we can use a strong palpating wave on peripheral arteries, and this should be counted for 1 minute. It is also important to know the value for age, because they vary. Slide. Should there be an alteration in the heart rate? If there is an increase, we may think of respiratory distress, bleeding, fever, pain. Some medications too, like atropine or adrenaline, may actually cause an increase in heart rate, while a decrease will indicate respiratory failure or an impending cardiac arrest. Slide. Capillary refill time is also another assessment when postoperatively. where it's normally supposed to be less than 2 seconds. If prolonged, it always indicates clinical anemia, but we are talking of postoperative case. So it's a sign of excessive bleeding. The child must have lost some blood. Slide. We will also monitor the temperature with a mercury in glass, axillary temperature every 4 hours. If the child feels warm, even if you've just taken it, repeat. And if elevated or low, we measure the temperature every hour. Should there be an increase, we think of an infection or environment. The child may have excess clothes on the body. There might be bleeding, dehydration, and malignant hyperthermia too cannot be excluded. Should there be a decrease, we think of exposure to, perhaps the child has taken some cold fluids or some muscle relaxants or vasodilating agents. It's possible. Slide. We assess the level of consciousness. The level of consciousness we actually use is a rapid way of knowing how this child looks like. We use the AFPU, where A actually means the child is alert, the child is orientated, or the patient is orientated. With V, the person only responds to voice. P, you need to tap the patient, hello, you have to tap, maybe pinch before the patient responds. And U is unresponsive. P and U are not good postoperatively. Postoperatively, we really have to make sure that we remain between A and V, if A possible, but P and U are not good postoperatively. Slide. Pain. Pain referred to as a fit vital signs if we include blood pressure, but we will not talk about blood pressure here because we are dealing with kids. It is important to assess the pain because if the child is in anything like pain, it's not good, but they have a similar way of manifesting. The child will be restless, lethargic, grimacing, pallor, anxiety, tachycardia. The child may be unconsolable, crying. We can use the face pain scale to rate the pain. Slide, please. Or what we use for the pre-verbal children is actually the FLAC score. Adults can self-report their pain, but the FLAC score, it means the nurse has to observe. The FLAC score is done over a few minutes. You have to be vigilant. Look at the face, look at the legs, the activity of the child, is the child crying, and the consolability. A score of less of 0, previous slide please. The score of 0 actually means no pain, 1 to 3 mild pain, 4 to 7 moderate pain, and above 7 is considered severe pain. Slide. After all, these are the main vital signs we assess. So after the assessment, the next thing we do is a nursing diagnosis. We are working here on possible nursing diagnosis, which could be the risk of respiratory obstruction or compromise. It is always almost present for children who have undergone cleft because they've got a new airway. We might also have the risk of bleeding, a risk of fever or hypothermia. There is also risk of cardiovascular and neurologic instability. There is a thin line between pain and discomfort, so the nurse needs to be vigilant about that. Inadequate hydration, because this child has to undergo, during the preoperative, the child has to undergo a period of fasting of nothing per us, and now we have to reintroduce diet. So it's important that we know the risk associated with that. There is risk of trauma to the wound side, and there is the need for the caregiver to be aware of everything that we have done, how they go home, take care of their children safely. When it comes to planning, the nurse just prepares her equipment, receive the patient safely, taking into consideration what is required before retrieving a child. She collects the patient safely using the monitoring list. She monitors vital signs, monitor neurologic status and the level of consciousness, like identify the resounding and postoperative complications which may occur. She manages pain. She promotes comfort. She assesses the surgical site. She maintains fluid and electrolyte balance, and she is the one who will have to reintroduce the diet for the child. She provides a thorough report of the patient status of the care she has given to the family, to the and other healthcare team, and she prepares the family for the discharge of the patient, documenting care provided to. In the intervention, as we already said, the nurse actually observed frequently for 15 minutes for 1 hour in the recovery, and 1 hourly for respiration, heart rate, oxygen saturation, level of consciousness, pain for the next 24 hours in the ward. 4 hourly for temperature, and check early if hypothermia or pyrexia. Position the patient in a high visible bed where the child can be observed instantly. There should always be an eye on the patient. We remember to position the child in a way that they should not irritate their wounds. Always put the child on the sides or on the dorsal position. We may have to restrain the child if it's necessary. The first post-operative feed is done by the nurse, not the caregiver, and she still goes ahead to supervise when it is the carer who is feeding. The child is fed in a prop-up position, and she rinses the mouth after every feed. We also have to remember analgesics and comfort. Make sure the patients are always comfortable. Should there be pain, during the intervention, we might start with the non-pharmacological means, because there is a thin line between discomfort and pain in children. So use all the non-pharmacological. Make sure the child is not hungry. The child is, we can cuddle the child. Did we wean the child? Did we have a nappy change? Or maybe the child just needs a change of position. Should this not work, we can proceed now with the pharmacological, which we begin with the simplest, like paracetamol, the non-steroidal anti-inflammatory, the opioids, and the strong analgesics. Slide, please. Now, as we earlier said, sometimes this nursing care is not always uneventful. Should there be laryngospasms, which would actually be a stridor from excessive secretions, we'll see an alteration. The nurse should be ready to call the anesthetist, open the airway, and give high flow oxygen. Laryngospasms, as we can see on the photo, is actually the closure, the sudden closure of the vocal cords, where the child will not have air. It's not possible. The next one we may have is laryngeal edema. It's actually an irritation from the endotracheal tubes, sometimes in difficult intubation, sometimes when some syndromic, like the Pierre Robins, they will always have, we might have this, or excess fluids too. If the child has taken excess IV fluid, we might find ourselves with laryngeal edema. The nurse needs to call the anesthetist. She supports the airway, give high flow oxygen with nebulized adrenaline in 3 cc of normal saline. Sometimes it helps while waiting for the experts to come. Residual sedation is a post-op complication which will lead to, it's like an over-sedation, where the respiration actually drops. So the nurse supports the airway, she gives high flow oxygen, but if the nurse thinks she's worried, she should call the anesthetist for reversal. It's important. Slide. Another real problem which occurs in the ward and which is always catastrophic is always aspiration problems. Aspiration problems are very dangerous. They occur in the ward, sometimes several hours. The theater is no longer open. The anesthetist may not be handy, and the nurse is in the ward, and this one occurs. there are actually secretions from the GI tract getting into the respiratory airway as indicated with the arrow. The nurse needs to open the airway, give high flow oxygen. If possible, do suctioning, but make sure you don't destroy the sutures. Start antibiotics, and sometimes there may be need for respiratory support, which means the patient might need to be reintubated. Bronchospasms too are common on the wards. These ones follow if there is a pre-existing asthma or other respiratory problems. We give nebulized salbutamol as a vapor and IV to reduce the edema, but it's important to call the anesthetist here. Should there be bleeding, it's important to put the child in a lateral position so that she doesn't aspirate the blood. Call the surgeon, call the anesthetist, give high flow oxygen. Resuscitation fluid should be started, but if the area or the site of the bleeding is visible, the nurse can apply a gentle pressure while waiting for experts to come. Slide. Other complications could include fever. If there is fever, inform the surgeon, inform the anesthetist, check the other vital signs, the heart rate, the respiratory, the saturation, the oxygen saturation. Do TEPI sponging, give oxygen by nasal specs. If there is hypothermia, wrap up the child, ask the mother to cuddle the child for body heat transfer. Avoid the use of cold or transfusion of cold fluids. If there is nausea and vomiting, we keep the child quiet, protect the airway. We continue with IV fluids, we delay oral intake, and we may give antiemetics if ordered. Slide. Other interventions also are the wound care. Wound care of the child with cleft lip repair. Place the child on the back or side only. Lying on the prone could cause a rubbing of the suture line. Discourage the child from inserting fingers into the mouth or touching the suture line. Use a blanket restraint for the very, very little babies or arm restraint for the older child. Teach carer the feeding techniques, not to disturb the palate repair or the cleft repair. No use of straws, no dummies. Spoons should not be touching the palate. We observe for sites, for the wound site. We clean the nose with cotton buds soaked in saline or a moisturizing cream. Slide. Preparing for discharge, we tell the mother, your child will feed little and often for a few days. So wound infections and pain can occur after any surgical procedure. Please ensure your child completes the course of his medications. Don't stop. Take note of potential signs of infection. If your child is having a fever, the child suddenly does not eat, the child is vomiting, diarrhea, you see some redness or discharge from the wound, know that there is infection, it's important to come back to the hospital. There shall be no removal of stitches, so it takes several weeks. Don't try to pick out the stitches, no. Make sure you respect all your appointments with the hospital. Give the child, you can clean the nose gently with cotton buds. You boil water, you allow it to cool. Don't take off the glue, leave it, it will fall off naturally. Slide. So the feed, give your baby milk, soft sloppy diet, feed the child in a propped up position, avoid foods that will stick on the child's palate or hard food that will cause discomfort, no straw, no forks allowed. Continue this diet for 3 weeks. Give a few teaspoons of cooled boiled water after feeding so that it can clean the wound. And after feeding, clean the child's mouth, apply some Vaseline on the child's mouth or the corners of the child's mouth if there is any sore. Like for the evaluation, we see it for ourselves. The evaluation is when you hand over a child to the parents and they are happy about it. They can cry about it. You know that your goal have been met, because at the end of it, we want put a smile on every child's face, one child at a time. So the post-operative nursing care concerning cleft surgery is very important. So SMILE training is actually providing a holistic approach which permits nurses to standardize nursing care. It involves critical thinking of the nurse and is based on knowledge and evidence base. So we can see the photo of some SMILE makers, how they are transformed. Thank you.
Thank you very much for that clear presentation. We'll have 10 to 15 minutes. Ms. Ruphine has been able to conclude our lecture in less than 45 minutes. Hello?
Hello, it's Ruphine.
Yes, Ruphine, yes, has been able to conclude our lecture in less than 45 minutes. So we have 10 to 15 minutes for questions. Can't see.
I'm listening. I'm getting the questions.
Participants did not make use of the Q&A. I can't find Q&A here. They didn't make use of the Q&A chat. So please, I can't find any question.
Hello, Dr. Kolawole. I think there's some questions in the chat room. I'm seeing one from Dr. Say. Which, are you able to say it?
Can you read it out? I'm looking for it. Can you read it out?
You say, thanks for this great presentation. In your opinion, how many days should a child stay in ward before discharge in absence of complication?
Okay.
How many days should a child stay in ward before discharge in absence of complication?
Okay, in my opinion, in my personal opinion, I suggest 48 to 72 hours. Without any, because during that time we have already gone through 48 to 72 hours. During that time, the inflammatory phase and the bleeding phase of wound healing, we are already above it. So if there is nothing without any complications, 72 hours, the patient can go home. I advocate 72 hours, 48 to 72 hours.
Okay. Thank you. I can see another question from this person didn't leave his name, Galaxy A71. Please, your personal experience in managing an immediate post-op complication. Thank you. This person wants you to give your personal experience in managing post-operative complication following clear.
Post-operative complications, in my experience with the patients I have already nursed, I have had one case of a forgotten pack. So it was actually in the recovery room, just a few seconds when this child was gasping for air. So I immediately called the anesthetist. I said, but this child, everything is fine, but he's gasping. I don't know what happened. And immediately he just opened the child's mouth and picked out the pack, and the vital signs were normalized. Another case actually was a patient, because as I keep on insisting on a thin line between discomfort and pain. So this child was actually restless. Using the FLAC score, I assessed a pain of 7. And I had to go through the documentation to find out when was the last analgesia given. It was barely 1 hour. So I was questioning the anesthetist. I can't understand why I am assessing FLAC at 7 and it's just 1 hour you gave anesthesia. I was a little worried, so I called in the parents. I said, could you please just come and check on your child? We have finished surgery, but this is 1 hour, your child can't come to you. Immediately the mother came in and talked to the child. It was okay. So the child was actually not comfortable with my presence. So the mother actually solved the problem, which I initially thought it was pain. So those are some of the experiences. We need to be vigilant. We need to have evidence-based to work better with our patients. Those are some of the 2 experiences I've had.
Thank you. Here's another question from Ibukun Ogundele. So, please, what's the role of special feeding bottles in post-op care following cleft repair?
Following cleft, if it is a cleft lip repair, I don't recommend special feeding bottles. I prefer a spoon or a cup where we use the side of the mouth, so that the child doesn't have to use the lip to do the suctioning. When the inflammation has disappeared, when the inflammation has disappeared, the child can start back the sucking. We advocate for breast milk in all its forms. If the mother can press it, if the child can take it directly from the mother, we advocate breast milk in all its forms. Should there happen that there is no breast milk, we can use specialized feeding bottles, which are pretty expensive in our context, because we work mostly with the mobile team. We might not even have. What we do is, if we can find one, we do just the cross. We make the hole a little bigger. We put it directly to cover up the palate. This now the case where there is a palate, there is a cleft palate which might not be repaired yet for the younger child. We do the crossing on the 13 on the head of the bottle, and we do the feeding so that the child doesn't regurgitate. But otherwise, what I always say is that there is this link between mother and child. They always get their position where they feed best. The mother, we say the prop up position, the football hold, but mother and child always have a position they have in common, which they feed best. And we should encourage that position, or we advise, we help mothers to identify the position which permits them to feed their child better. Thank you.
Thanks. There's a question from Ghong Beltus. I doubt if the question is within the scope of this lecture. It says, can you tell if the fetus will have a cleft palate? What other ailments are they likely to suffer from?
Although that question is not really in my competence as a nurse, but it's possible to know. It's possible to know that the fetus will have a cleft. And since smile train is already there, it's not like we are surprised. We already have a team which knows the site. It's a comprehensive care thing. So we have the social worker, we have the psychologist who will prepare. We have the midwife, we have the nutritionist, we have everybody in the team who has a specific role in the management of this child, even intrauterine, extrauterine, postoperatively, intraoperatively. I think everybody has a role in the care. Smart Train has the possibility. Yeah, thank you.
Thank you. There's another question from Ibukun Ogudele. There's also use of restraint has been a challenge in our practices in Shagamu, Nigeria. We use boxer gloves. Do you have further advice for us from your experience?
From my experience, when it's a bigger child, a child below 9 months, we just take the 20%, the 250 ml normal saline, and we put as a bandage on the elbow, so the child doesn't have the possibility to take up the hand to the face. But it is important to turn the child. The child needs to be distracted from time to time. We undo the bandaging every 2 to 3 hours so that the child can feel free, and then we put them back, at least for the first 24 hours. Then later on, but if it's a child who is cooperating, we do the restraint. We just put a blanket over the child with the arms inside. The mother can undo it from time to time, and then she ties it back, and the child is comfortable, just to make sure that he or she doesn't touch the wound. But the greatest challenge is actually the thumb-sucking children. The children who suck their thumbs or fingers. It's really a nightmare, but there is always a minimum way of doing. Sometimes, if it's really a palate repair and there is nothing to do, the anesthetist sometimes keeps them in a mild sedative state, so that the sutures can adhere for the first 24 hours, and then we continue the monitoring afterwards.
Thank you. The next
Yeah.
question is from Dr. Timothy. What will nurses do if parents ask for discharge immediately after surgery? Despite
Sorry?
What will nurses do if parents ask for discharge immediately after surgery, despite the explanation? Why the baby needs to spend few days at hospital?
I think if they are asking discharge immediately, then there was a problem at the level of the preoperative care. Because during the preoperative care and the signing of the consent, we normally tell them how long their child will take. We teach them everything they will see on their child postoperatively, what will be done on the child. If the parent has understood what will be done on the child, I don't think a normal parent will request for the child to go home, knowing fully well the procedures that the child has undertaken, the anesthesia, the risks of complications, and just wants to go with the child. I think there might have been a little lapse at the level of the preoperative preparation, preoperative nursing preparation. My opinion, anyway.
Thank you. I think we have come to the end of all the questions. We have answered all the questions. Others are just commendations from participants, and I want to join them in again appreciating the presenter for that brilliant presentation.
Thank you.
Yes. This is the end of the lecture for today, and I want to remind our participants that this lecture session, series of lectures come with CPD certificate, and that will be given at the end of the lecture. I mean, we'll cover tomorrow's lecture, so let the participant bear in mind that there is CPD certificate attached to these telecleft lectures. So I hand over to Renee from WCS to round over, conclude this session of this telecleft lecture.
Thank you very much, Dr. Kolawole, for moderating. We thank the presenter. Really interesting session we've had today. We want to thank Smile Train and Philip Shelbuara, the Secretary General of the West African College of Surgeons. We have really had a very good session. This is our last week, and we should be wrapping up this series of lectures tomorrow. Like the moderator said, we indeed want to award continuing medical education points to this series. They're going to send out some information for you to complete so that we can appropriately give you your awards. And we also appreciate feedback from you. We've had many weeks of teaching, and we would like to have a feedback. So we're going to send out post-testing evaluation survey, and we encourage you to kindly fill that. The forms will be out tomorrow, and we appreciate feedback so we can know how to improve. So the CME points will be available. You will get information by email, and we'll still want to continue our series tomorrow. Thank you, Smile Train. Thank you, West African College of Surgeons. And we thank the presenter and the moderator. See you tomorrow, same time.
Thank you.
Bye, everybody.
Bye.